Hello, I'm Janet Gwiazda, a member of the Seminar Planning Committee. I want to thank you for joining us and being part of the BIANJ annual seminar today. Before we get started, I would like to remind everyone to enter your full name in the chat function. That will be your virtual sign-in. If you're going to request CEUs, you must stay in the workshop for its entirety and complete the evaluation. If required by your discipline, you may also need to include your signature or complete a post-test. I will be entering that link in the chat for your convenience, and Zoom will provide a report of how long each of you stayed in the workshop. CEUs cannot be granted if attendance cannot be verified. Now I'd like to present our presenters for the workshop, A Progressive Shift in Traumatic Brain Injury Populations, Unique Challenges in Treating TBI in the Elderly. Our presenters are Dr. Sue-Ann Chen. She is currently the medical director at Shore Rehabilitation Institute in Brick, New Jersey, which is affiliated with JFK Johnson Rehab Institute and located within Hackensack Meridian Ocean Medical Center. She is a board certified physiatrist and subspecialty certified in brain injury medicine. Our other presenter is Dr. Fish. Dr. Peter Fish is board certified in internal and geriatric medicine. He has extensive experience with brain injury, both as a U.S. Army doctor in Iraq and Afghanistan, and as a medical director for numerous nursing and rehab facilities. So I will now turn this over to Drs. Chen and Fish, and please actively participate in this webinar. Thank you.
Thank you so much, Janet, for that introduction. I appreciate it. Again, I'm Dr. Sue-Ann Chen. A little bit of background on this topic and how we chose this topic. So there's been a lot of research in the past and a lot of focus and spotlight in the past on sports concussions. I think that's what really brought traumatic brain injury to light. Even recently in the military related TBI as well. But this is a growing population. This is something that is seen everywhere now. And I think it's not being discussed enough, the population of the elderly. A little bit of background from me. I'm a physiatrist. I'm a physical medicine and rehab physician with and I did my residency in New Jersey at Kessler, and then I did my brain injury fellowship at the Rehab Institute of Chicago, which is now called the Shirley Ryan Ability Lab. After that, I went to Lehigh Valley, Pennsylvania, and ran the brain injury program there. But I wanted to come back to New Jersey. So now I'm back at in Ocean County at Ocean Medical Center at the Shore Rehab Institute. What I found when I first got to Shore Rehab and New Jersey in Ocean County, New Jersey, was that there's a big geriatric population there. All of my training had really taught me to treat brain injury, specifically in a younger population. And so I had to make some adjustments in my treatments and some of the diagnostic treatments and considerations when I talked about the geriatric population. And I felt that this wasn't talked enough in the literature in general. One of the patients that I had discharged to a Lair subacute rehab in Freehold, I had discussed the case with Dr. Fish, who was the medical director there at the time. And I realized that he's a geriatrician, and I thought this would be a great opportunity for us to collaborate to bring you this discussion on this population. So without further ado, we'll move to the lecture outline. We're going to cover some broad topics within this population, including epidemiology, morbidity and mortality, the pathophysiology of the aging brain, mechanisms of TBI, and primarily it's falls. So the causes of falls in the elderly. We'll go back and talk more about outcomes of TBI in the elderly, some specific treatment considerations and rehab considerations, as well as TBI recognition and fall prevention. So to start, we'll have Dr. Fish present a case.
Thank you, Sue-Ann. So here's our case. This is a very typical case, which is why we chose it. So we have an 81-year-old male who's brought in by ambulance to the ER after a fall with a loss of consciousness for a few minutes and disorientation upon awakening. The patient is incontinent of stool and urine, and he keeps repeating, "Where am I? Where's the court?" And he becomes agitated, at which point he's given Haldol. He's been in the ED before with a twisted ankle, so he is recognized by the ED staff. Review of the old records show that he has a past medical history of coronary artery bypass graft, hypertension, and benign prostatic hypertrophy. He's married, he's a former smoker, his vital signs are stable, and he's afebrile. The physical exam is normal. They do some labs on him. They find that his urinalysis is positive for bacteria. His other labs are within normal limits. An EKG shows some Q waves, but otherwise normal. Chest x-rays within normal limits. A CT head does not show any mass or intracranial hemorrhage, but it does show some cortical atrophy. He's diagnosed with a urinary tract infection, dementia, delirium from sepsis, and he's referred to a subacute rehab.
So with that typical case, let's talk more about geriatric TBI. So this is a busy slide with a lot of statistics and numbers, but I did want to highlight some of the statistics and numbers. First of all, 40% of adults in the US will have some type of traumatic brain injury in their lifetime. And the number of traumatic brain injury incidents is growing yearly. It's now at about 2.8 million per year. Some of that might be due to an increased awareness of TBI, especially with sports concussions being highlighted recently in the past few years. But in general, it's a growing number. And the cost overall is $76 billion per year. The CDC does statistics on TBI. They did a thorough analysis between 2002 and 2006, but then also in 2007, they did a thorough analysis. And in 2013, they also did a thorough analysis again. And they found in 2013 that more than 1 in 200 Americans aged 65 to 74 had a TBI-related visit, ED visit, hospitalization, or death. So they kind of put all those three in the same category, ED, HD. And then for Americans ages 75 and older, there was more than 1 in 50. And that number had doubled from 2007 to 2013. In fact, it went so high that it actually exceeded the population growth during that time frame. But it wasn't just in US, it was noted throughout the US. Specific individual states noted it in there, and there have been studies reported on each of those individual states, but also around the globe. That was the same trends were noted in Spain, the UK, Scotland, Netherlands, Austria, Finland, Canada, Australia. And in general, the population is just aging. In 2008, on the left here, the US Bureau of Census noted that they believe that by 2040, greater than 20% of the population will be at least 65 years old. And 3.7% will be greater than 85 years old. And if you look at this, this on the left here is currently on the US Census Bureau website. This is specifically from 2017, but they talk about how for the first time in US history, older adults are projected to outnumber children by 2034. So you can see that the projected percentage of the population was greater of children before in 2016, but there's an inflection point in 2034 where adults greater than 65 will actually outnumber the number of children. And it's projected to continue that way up into 2060 is their projections. In looking at this, when I was in training at Kessler and RIC and back in the early 2000s, I had been taught that, and I think already that was changing, but I had been taught that TBI was specifically more in this age range here. This age range of 15 to 24 maybe, and then to mostly up to 34. So it was really this age here. And the peak was really big in this area. There was a lot of, again, this is the total number of TBI. This is the number of ED visits, hospitalization, and deaths. And in general, there was a big peak here. And that was primarily because, as I was taught, it was young and dumb. It was mostly males with risky behavior, motor vehicle accidents, motorcycles, snowboarding, skateboarding, all of those kinds of things. And then, you know, as my training went on, it became a bimodal peak. So it was this area here and this area here, which was the elderly and the beginning of a growing elderly population and more falls in this age range. And as you can see, in 2007, the elderly population is just rising and rising. It is likely that some of this behavior back here has improved in terms of its in terms of the statistics because of safety considerations like seatbelts, helmets, those kinds of things. But this growing population of elderly and this level of falls is significantly increasing. So now there's more than 80,000 ED visits each year in those 65 and older, and 75% of those require hospitalization. And then those 75 and older have the highest rates of hospitalization, 3 times more than younger than that, and the highest rates of death. And in general, TBI is now a major cause of all mortality. About 30% of all injury-related deaths are from a brain injury. In looking more at the epidemiology, let's talk first about this, this line here. So this line, this is the percentage of TBI patients by race. And in general, it tends to be more Caucasian individuals. And this really just mirrors the demographics of the US aging population. In general, Caucasians are living longer. But what I really want to focus on is males versus females. So I had just mentioned that I had been taught that it was males that were young and dumb doing risky behavior. And in the younger ages, it still is more males that have brain injuries. But as you go older, at age 75, you do notice that there's equal risk. So males and females are 50-50. And then after age 80, women are much more likely to have the TBI. And in general, compared to younger adults, older adults with the TBI are more likely to have more in-hospital procedures, more imaging and neurosurgical procedures. They're more likely to have longer hospital stays. They're more likely to require continued medical care. And compared to younger patients, those with ages 65 and older are 3 times more likely to receive a CT of the head when they're in the emergency room compared to younger patients. And they're 4 times more likely to be admitted to ICU, step down, or a surgical unit. And in general, outcomes are poorer. Every 10 years of age, there's a 40 to 50% increase in the odds of a poor outcome as a result of the TBI. In terms of mortality, when you compare mortality in individuals 65 years or older with those younger than 65 years, the rates can vary a lot. But older patients in general have higher rates no matter which classification of injury severity, whether it's mild, moderate, or severe. The highest rates of mortality occur during the first 48 hours, regardless of age or severity. There was a chart review in 2013 by Hirshana et al. Of patients who were 55 years and older. They looked at the TBI model systems database that collects all of the data of TBI in those centers from 2003 to 2009. And they compared the patients who died 1 to 4 years later, so within the first 5 years, with patients who did not die within those first 5 years. And they did find that increased mortality was associated with certain characteristics, including a diagnosis of abnormal gait. They were more likely to have prescriptions for respiratory medications in general. They were more likely to have prescriptions and diagnoses of diabetes. And in general, they were more likely to have more medications compared to those who did not expire in those first 5 years.
So normal brain aging. This is obviously very important to our population because the brain aging correlates both to for causes of falls and also more sensitivity to damage as a result of falls. So brain aging mirrors the aging in the rest of the body. In the rest of the body, we're very familiar with the fact that joints and different tissues are more prone to inflammation, particularly after traumas. You also have accumulation of intra and extracellular proteins in the rest of the body. They often manifest most visibly as age spots. And then you have decreased glucose metabolism manifesting in the rest of the body, often as fat deposition and lack of energy. And then microvascular changes are not necessarily so visible. Well, and then also you have atrophy of muscles and things like and fat, which is what makes your face look like it ages as you get older. Well, these things are paralleled in the brain. You have atrophy of brain tissue as a result of cells that die being replaced at a lower rate. You also have loss of cytoplasm within each cell. There's a degree of inflammation that is and that's implicated in a lot of diseases, including heart disease and Alzheimer's. And in the brain, there is a lot of research right now into the proteins that deposit in the cells and around the cells, including beta amyloid proteins, which are found outside the cells, and tau protein tangles, which are found inside the cells. Decreased glucose metabolism is visible mostly on PET scans. When you compare an older brain to a younger brain, you have the hotspots are not as intense and as varied as in a younger brain. And then also you have microvascular changes. Those microvascular changes can be a result of or a cause of bleeding and ischemia within the brain. What do you see on either pathology or autopsy after a patient dies? You'll see a shrunken brain. And if you do MRIs or CTs, you will see much larger grooves and a much smaller area occupied by soft tissue of the brain. On this particular sagittal cut, you'll see to the left a healthy brain, which occupies most of the intracranial space with very little black, which represents fluid. And then over on the right, you will see a typical 80-year-old brain with cognitive loss. And you'll see that there is a loss of hippocampus on the lateral side, the lateral areas, lateral medial, and then decrease in axons and increased size of the gyri, which is replaced or filled in with the cerebrospinal fluid, which is represented by the black. I will mention later, I'm sorry if you go back to that slide, I'll mention later, but it's just worth mentioning right now, that you will also see brain atrophy and these changes in people who do not have any cognitive loss. So when somebody does a CAT scan or an MRI of somebody who's 80 years old and they find an atrophic brain, that does not prove that they have dementia. All it shows is whether they have or don't have an intracranial bleed or a mass or a shift or something like that. If they have dementia, it is often correlated with the atrophic brain. But the atrophic brain does not show that people have dementia. That's an important point. Okay, I'm sorry, you can go to the next slide now. Okay, so Sue-Ann, did you want to take this one or is this me still?
This is you.
I think that's still me. Okay, so age-associated brain changes occur after about the age of 40. So after age 40, you can actually see the shrinkage of the cytoplasm in cells if you were to do a biopsy or you were to do a PET scan, or rather an MRI. Age-related cerebral atrophy can happen from 3 different reasons. One is you can actually have loss of neurons, and that is when neurons die from apoptosis, they're not replaced either at all or as quickly as in a younger body. You can have decrease in neuronal volume, which is the decrease in cytoplasm. And then you can have loss of synapses, which means the interconnections between the different cells can actually be demonstrated to be decreased. There may be a decrease in the synthesis of nerve growth factor, making neuronal repair more difficult. That's not proven, but it is shown that if you have a decrease in nerve growth factor, you definitely don't make the repairs. It's not proven that that is a common across the board factor. In people who do have decreased amounts of nerve growth factor, it certainly will have implications in terms of remodeling and healing after an injury or some kind of insult. Age-related cerebrovascular changes can lead to reduction in cerebral perfusion. Obviously, if your blood vessels are not as healthy as they were and they're decreased in size and perhaps they are occluded, then you're going to have ischemia or relative ischemia to different parts of the brain. And that's going to result in reduced cerebral metabolism and decreased functioning of the neurons. And then the overall shrinkage due to atrophy increases the space between the brain and the dura mater, which means that the blood vessels which branch across from the dura and from the dura to the actual brain tissue are going to get extended. And when they are extended, that means they're more vulnerable to shear injuries when you have coup and contra coup movements of the brain. That makes them far more vulnerable to shearing, bleeding, and the manifestations of TBI. So you have different injuries in different age groups. Most people are familiar, most people in this business are familiar with the typical injuries that you get in younger people, and you are familiar with the trajectory of healing. You'll find that older adults have other health problems that can affect their recovery. It would not be typical that you would have rehab for a 35-year-old interrupted by chest pain or interrupted by pneumonia. That's not typically what happens, but it is very common in older people, so that you may be making progress with their TBI rehab, but then it gets interrupted by the fact that they get sepsis from pneumonia, or they have to go to the hospital for a period of time because they've had chest pain, or any number of other complicating issues like diabetes that's poorly controlled. So that's one thing that can have a major effect on rehab. Also, the older brain has a decreased ability to repair itself, which was mentioned earlier with the factors that are not necessarily as active in the older brain, so it doesn't heal as fast. Now, this second box is a little confusing. So you have two broad categories of the TBI. You have the focal injuries, which are the easiest ones to spot, focal injuries that include contusions, lacerations, et cetera. And then you have diffuse injuries, which includes the diffuse axonal injury. But then you also have a division of injuries into primary and secondary. So your primary injuries are going to be the ones that happen immediately when you fall and you strike your head, or you are stopped suddenly and you have your brain sloshing forward where you have a coup injury, and then your brain sloshing backward, and then you have a contra coup injury. Those are the classic primary injuries. And then you can have secondary injuries, which can result after the fact. And your secondary injuries can be a result of, for example, brain swelling, where you have edema, and the edema can increase the intracerebral pressure, which can reduce perfusion, and then you can wind up with ischemic injuries after the fact. You can get toxic injuries after the fact. You can have slowly growing bleeds, hemorrhages that can cause terrible injuries 24 hours after the fact. So once again, you have two different axes. You have your focal versus your diffuse injury, and then you have your primary injuries versus your secondary injuries. So that can be somewhat more confusing in the older people because you have these different variables to consider. Next slide, please.
Okay. So we talked a lot about TBI in the elderly in general, but now we can start talking about what are the main reasons for the TBI in the elderly. In general, in the general population, not just the elderly, the leading causes of TBI, again, I had mentioned before that it was mostly due to motor vehicle accidents in the past. But over time and in the, since 2006, in 2003 and 2006, really falls has taken over, and largely due to the change in the aging population. Again, previously there was a big chunk from assaults and gunshot wounds. There were brain injuries from being struck by or struck against. And then there were other causes as well, but really falls was the primary aspect of brain injuries now. If you look at this slide, this graph here, it shows that with age, falls becomes a bigger portion of the reason for brain injuries. So prior to age 75, maybe prior to age 65, really, it's a lot of motor vehicle accidents that cause the problem. And some other things that are listed here as well. But really, once you get to age 75, it's mostly at least almost 75% of it is due to falls. So TBI related falls. So 1 in 10 US residents 18 years or older and 18 years old or older report falling every year. So there's falls in general. But in ages over 70, it is the leading cause of hospitalization. And in ages 65 and older, it's the 5th leading cause of death. And in people over age 75, it's 70% of deaths due to injury. From 2008, again, looking at the statistics from that of TBI related deaths from 2008 to 2017, the fall-related TBI deaths increased by 17%. It increased in all age groups, but specifically in those 75 years old and older. And age was really the highest risk factor. It was noted also to be more of an issue in non-metropolitan counties. But in general, age was the highest risk factor for increasing fall-related deaths. And it's interesting to note also that the rate of fall-related TBI death in those 75 years and older compared to those 55 to 74 is actually 8 times higher. So in general, once you get to 75 and you have a fall and a TBI, you're 8 times higher chance of having a fall-related death. Dr. Fish?
So what are the causes of the TBI? Note, by the way, that when you look at the pie graphs of causes of TBI in younger people versus older people, you just saw a pie chart, which is very typical, which shows that there's really very few causes of TBI in the older people. There's the motor vehicle crash, assault, struck by, and then falls. You'll find in younger people that falls is often broken down into many other subcategories, bicycles and motorcycles and skiing and sports and things like that. Presumably the assumption is that old people don't do anything, they just fall. So that's an interesting point, and I think is worth noting. So what are the two big causes, or the two categories of causes of TBI in the elderly? Well, there's the primary causes and the secondary causes. The primary causes are typical, not just in the elderly, but everyone. Everyone is susceptible to falls, physical abuse, motor vehicle crashes, falling during normal daily activity, slipping on the ice or on a wet floor, et cetera, and assault. What's more common in the elderly? Everything above, plus pre-fall fractures and Parkinson diseases. So pre-fall fractures are when you're walking along and you have osteoporosis, and your hip snaps and you fall as a result of your hip snapping while you were walking, and then you strike your head on a counter or a chair on the way down. That typically does not happen in anybody other than the elderly. Parkinson diseases, which we now recognize as a spectrum of diseases, including things like Lewy body dementia and frontal lobe dementia, et cetera. These are far more typical in the elderly, and they certainly can lead to falls. What are the secondary causes of TBI? Well, secondary causes, first of all, in everyone, are substance abuse. People who are drunk or stoned or high are far more likely to fall and hit their head. People who have underlying psych diagnoses, who are delusional or have personality issues and get into violent altercations. This is true of everybody, including the elderly. What's more common in the elderly? Let's see. Hang on a second, looks like I just lost my lead here. Well, what's more common in the elderly are iatrogenic causes. For example, when you get side effects from medications. So you can get things like orthostatic hypotension as a result of medications. You can have altered mental status from painkillers and from muscle relaxers, etc. In addition to that, you can have loss of sensorium. So if you can't see because you don't have your glasses with you, or you've not had your prescription updated, or because the lighting in your house is not particularly good. You can also have a lack of hearing because you have impacted cerumen or accumulated earwax, or because you don't have hearing aids, which happen to be very expensive, or because your hearing aids are not turned up or the batteries are run out. A lot of people don't understand that, but we are at a subliminal level always listening to our surroundings. And if you're unable to hear things and get feedback from your surroundings, it's much easier to fall as well. Okay. Sue-Ann, you need to go on because I've just lost the slide. I can't see it. So while I'm coming back, maybe you can, or while I'm finding it, maybe you could continue.
So I'll just read off this slide, number 16. Okay. So it's just a summary basically of all the things Dr. Fish had just mentioned, the risk factors for falls in the elderly. Again, impaired vision, impaired proprioception, impaired vestibular function, and peripheral neuropathy are big ones. In general, arthritis and muscle weakness and osteoporosis are really things that should be considered for as risk factors as well. The big one that I see frequently in the acute inpatient rehab is postural hypotension, orthostatic hypotension. And then there are also movement disorders, depression, and dementia, which are risk factors for falls in the elderly as well. In general, the big one is the pre-existing comorbidities. In the UK, there was a study of older adults with TBI, and 11% had pre-existing dementia, 22% had pre-existing hypertension, and 99% had at least one pre-existing medical condition. And usually they all had at least one of diabetes, cardiovascular disease, pulmonary disease, renal disease. And especially in moderate to severe TBI, there was cardiovascular and endocrine disorders, which were 5 times more frequent compared to those who were younger, between ages 50 and 54. So with all these comorbidities, it's really that fewer are dying from the injury itself and more are dying from the pre-existing medical complications. In general, older adults are more susceptible to medical complications. Dr. Fish had mentioned the frailty of the vasculature, which leads to more cerebrovascular events, especially due to that hypotension and that orthostasis. They are much more likely to have adverse effects of anemia due to blood loss during the trauma. And they're more likely to have pulmonary and cardiac complications, especially with patients that have a history of CHF or other underlying medical complications. And as a result, compared to younger people, older adults with TBI have poorer short-term functional outcomes, worse functional outcomes in general, and greater levels of disability. There was a study of people over 55 compared to people younger than 55. Now, granted, this is 55, not what we traditionally consider as geriatric. They were matched for injury severity and gender. The older group in general had a significantly longer mean length of rehab stay, higher total rehab charges, slower rate of improvement on functional measures, and a higher rate of discharge to a nursing home in this acute inpatient rehab. However, in TBI model systems data, when looking at, in 2013, when they looked at the data from the centers of TBI model systems, almost all individuals who were over 65 who had received acute inpatient rehabilitation did achieve significant functional improvement. 2/3 were discharged to the community setting, and nearly 85% were still in the community setting 1 year later. As I showed in that mortality slide, injury severity is important. But in cases of TBI that was uncomplicated by multiple trauma, older adults do have the potential to achieve functional outcomes, and they're comparable to younger patients. It just may take longer, and it might be a greater expense. In general, we don't have great research in terms of looking at outcomes. And a lot of this is the next stage of research being done. Research in TBI has generally been looking at Glasgow outcome scales as the primary measure of outcome measure. But that doesn't really adequately quantify TBI-related functional impairment in a geriatric population. There was a study that compared health-related quality of life measure, the HR-QOL, compared to the Glasgow outcome scale, and they showed that there was a difference in HR-QOL. Quality of life did change, even though the Glasgow outcome scale did not find that difference in this geriatric population. But really, a lot of studies are being done to try to predict how elderly will do. There are two specific models that have been looking at elderly TBI outcomes. The first one was the CRASH model, the corticosteroid randomization after significant head injury. They looked at, it was a model that predicts 14-day mortality and 6-month unfavorable outcome. And again, it looks at the Glasgow outcome scale. The only variables involved were age, GCS, pupil reactivity, extracranial injury, and evidence of trauma on head CT. So it didn't look at comorbidities. It didn't look at pre-injury function. And again, the IMPACT model, which was the International Mission on Prognosis Analysis of Clinical Trials in TBI. This was another one that predicted 6-month mortality and unfavorable outcome on Glasgow outcome scale. And again, that included variables of age, GCS, pupillary reactivity, hypoxia, hypotension, CT evidence of trauma, and blood glucose and hemoglobin levels. So they did look at some blood glucose and pre-hemoglobin levels compared to after. But really, those were the only variables that were taken into consideration when looking at outcomes. And these were mostly neurosurgical studies looking at outcomes specifically of after neurosurgical interventions have been done. But the problem with these models, they're not good models. You need to incorporate comorbidities. There's a huge portion of geriatric TBI that's related to comorbidities. We need to look at polypharmacy and all those medications that interact with each other. And they really need to look at baseline function, whether it's discussing with the family or discussing with the patient how they were doing before the brain injury. Or there are certain studies that are being looked at for measures of frailty to predict how outcomes will be after the geriatric TBI. But in general, there's very few studies of outcomes after geriatric TBI that really look at pre-TBI functional status assessments. And very few, even fewer studies have looked at that pre-TBI functional status and how that prognosticates for outcomes in the future. Now, when we're looking at brain injuries and we're talking about treatments, so again, I came to Ocean County, New Jersey, where there's a big geriatric population, and some things I had to do a little bit differently than when I was dealing with the younger population. First of all, even in the acute care side of things, there's still some controversies over whether ICP intracranial pressure monitoring is beneficial in these patients. There are a few studies out there looking at whether a craniotomy, where you put a hole in to drain out the hemorrhage, versus a craniectomy, where you remove the skull to take out to relieve the pressure and take out the hemorrhage, is more beneficial. There's also a lot of controversy over when is okay to restart anticoagulation or antithrombotics. Again, these patients, a majority of them have atrial fibrillation or an increased risk of stroke or cardiovascular disease and need to be on something like aspirin, Plavix, or Coumadin for atrial fibrillation. A big portion of my day in my acute inpatient rehab service is trying to figure out with the neurosurgeons and the neurologists whether it is okay to restart these these blood thinners in general. because it's a risk benefit of whether it's more likely to bleed or more likely to clot. The other thing I learned when I first started was I was I was always taught for medications to start low and go slow. So I use a lot of neurostimulant medications. Folks who work with me who are on the line might tell you how I'm constantly using Ritalin to help with neurostimulation in these, even in the elderly population after brain injury, to help with attention deficits and initiation deficits. However, the normal starting dose that I would use in a younger patient, I had to half that. So Ritalin was a good example. I start much lower. Another good example is for sleep meds. I like to use trazodone for sleep. It has a very interesting profile, and at different dosages, they have different, it has different receptors, hormone receptors that it targets. So while it's an antidepressant at higher doses, at lower doses, it's a good anxiolytic. And also at slightly higher doses than that, it's a good it's good for insomnia. So I start usually in younger adults at a dose that's good for insomnia, which is usually maybe 75 to 200 milligrams of trazodone a night. But in these elderly patients, I have to start lower. So I usually start at 25. So those things I had to kind of adjust. And I mentioned also that there's a lot of orthostatic hypotension. The body does not respond as quickly as in the younger population in intensive rehab and being with changes in position. So orthostatic hypotension happens frequently. Sometimes it takes a few days before these elderly patients can adjust to the intensive rehab. And I'm constantly putting on abdominal binder and TEDs or compression stockings to both legs when up, right, to help with that orthostatic hypotension and the blood pressure issues. In general, these patients are at increased risk for ischemic and hemorrhagic stroke. TBI in geriatric populations have shown an increased risk of depression, 11% increased risk. And in post-traumatic stress disorder, there's a 50% increased risk. So in general, also, they have just generally a slower cognitive recovery. I've seen that specifically my younger population of TBI, they can be on my acute inpatient rehab and we'll see a much quicker recovery of cognition and post-traumatic amnesia and post-traumatic agitation. And they tend to come out of those phases more quickly. But in general, there's a slower cognitive recovery in these elderly patients. But they can have an equivalent or better cognitive outcomes compared to younger individuals with TBI when adjusted for expected age-related decline, as found by Matthias in 2015. And in general, rehab treatment considerations, Dr. Fish mentioned that you have to optimize vision and hearing. Sometimes, you know, that hearing aid is really important or that making sure that vision is optimized in terms of the correct drops for glaucoma, the correct artificial tears for dry eyes. Those can make a big difference in the outcomes that you see in rehab. In general, for self-care, the therapies really need to be focused on the older adults' pre-injury habits and routines, because lots of it is about routine. So you need to incorporate their own clothes and utensils and make them into familiar routines. Again, it takes the older adult longer to recover mobility and balance. And there's premorbid issues with cognition, sensation, strength, and balance that play a role into this this increased difficulty with recovering mobility and balance. And I mentioned also they just generally have less tolerance, especially in the beginning, for intensive therapy sessions. So it takes a couple of days more to really increase that tolerance. And part of that is the lower endurance, and a part of that is more muscle and joint stiffness. So increasing barriers with age, you know, functional capabilities decrease. And then additional medical problems may emerge. Dr. Fish mentioned earlier, the chest pains and the pneumonias, those occur more frequently in the elderly due to all the medical comorbidities and the frailty to begin with. But there's also a psychosocial component that that needs to be dealt with these increasing barriers with age. So there's different social roles and relationships. There's higher rate of psychological problems, including depression, addiction, and suicide. And then there's also the problem with just disposition and housing and community access. A lot of these, all of my patients, when they leave acute inpatient rehab, really need someone to supervise at home, just because of difficulty with divided attention and multitasking. And the problem is that the caregivers are usually spouses, often spouses who are also elderly, and may have their own difficulties with cognition as well. Or they may be widowed, and then it's really dependent upon family, who are often younger and often working and unable to provide that supervision. So there become increasing barriers with age that it really should be an advocacy effort, I believe, to really try to find more resources for these patients. Dr. Fish?
So one of the complicating factors of treating a TBI in the elderly is the fact that it is very easily conflated with dementia. It is not only confused with dementia, but there also seems to be a predisposition toward dementia when people have traumatic brain injuries, often as younger people. So there seems to be some Alzheimer's disease as well as Parkinson type diseases. I think most people are familiar with Muhammad Ali and the fact that he developed Parkinson disease later in life. That was a fairly common result seen in people who were involved in professional boxing. And so it has the name dementia pugilistica as a result of, because it was observed that people who have traumatic, frequent re-insulted TBIs often get Parkinson's type diseases. So there was an analysis for about 6 years in the state of California, in which they looked at a little over 51,000 patients, almost 52,000 patients. And they found that the people who were at higher risk for dementia were people who had moderate to severe TBIs over the age of 55. And then people who were over the age of 65 who had mild TBIs also had a much higher rate of developing dementia. And they were compared with the patients, of course, who did not have any TBI at all. Patients with dementia, a lot of people are very focused on the fact that there are plaques and atrophy. I mentioned that earlier. But one of the big mysteries in researching this is the fact that the presence of plaques and atrophy does not dictate whether you have dementia. People will often self-refer, or children of patients with early cognitive decline will be referred to neurologists. And what, of course, will the neurologists do? In addition to some physical exams, they'll send patients for an MRI or a CT. And patients mistakenly believe, and some physicians mistakenly believe, that if you don't see atrophy, then the patient doesn't have dementia. And if you do see atrophy, they do have dementia. They just may not be manifesting it yet. Both are wrong. There is a correlation between atrophy and plaques and dementia, but we have not demonstrated that is a causative relationship. And now let me make the second point. And that is a statistical misinterpretation that people often have. Dementia does occur more in the elderly. But here's the point I want to make. The majority of the elderly population does not have dementia. So there are over 49 million Americans currently. I think Dr. Chen quoted a recent statistic that showed a little over 50 over the age of 65. 12% of them have dementia. So 12% of 49 is about 5 million people. That's a tremendous number of people. However, that means that 43 million Americans, 78%, don't have dementia. Consider what your assumptions are, however, if somebody comes into the emergency room or you see somebody with gray hair. Your assumption, typical, it's not just you, it's most people, assume that if people are older, they have dementia. But the numbers do not bear that out. That is a bias that we have to be aware of in medicine. So why does that matter? Let's go to the next slide. It matters because false assumptions and biases can have an effect on how we treat people. What are the assumptions of emergency department personnel about older patients when they present with an altered mental status? If somebody rolls into the emergency department and they have altered mental status, what's the first thing that happens? They get triaged, and they get triaged to see either the attending or the physician assistant or nurse practitioner. Who do you think sees most of the older patients? It's not the attending. It's usually the PA or the NP. Now, on what basis do I say that? I say that on the basis of having a medical license in 13 states and being a medical director at almost 15, I think 15 at last count, medical rehabbing nursing facilities, and consistently seeing the same thing across a large swath of the country. The attending does not see older patients typically. So what does that mean? That now means that the physician assistant and the nurse practitioner see them because they've considered to be, they're automatically considered to be lower acuity. It means that if the PA or the NP is seeing the patient, the trauma team is not seeing the patient, right? Also, how much training does the NP or the PA get? Well, I was a PA before I became a physician, and I can tell you that our geriatrics training was about 1 hour. In medical school, our geriatrics training was about 2 hours. That's not much geriatrics training. So the problem is that people assume that they know what geriatrics is just because they see a lot of older patients. So I've encountered cardiologists who say, well, all of my patients are older, therefore I know geriatrics. But that's like a male doctor saying, oh, half of my patients are female, so I'm a gynecologist, right? That doesn't make any sense. All right, so let's go on to the next point. If somebody comes in with altered mental status and they're 30 years old, the assumption is that they were fully functioning before they had whatever this altered mental status was, and therefore they must have been an insult of some kind that caused that change in mental status. If somebody comes in who's 80 years old and they have altered mental status, most of us assume that they've been that way for a long time and it's just dementia. Who's the only person who's going to contradict us? Who's going to tell us that there was something different? Who's going to tell us that granddad was playing tennis yesterday? Who's going to tell us that mom was teaching astrophysics yesterday? Well, nobody's going to tell us that during COVID because no family members are allowed in the emergency room, right? I mean, maybe they have one family member who's allowed in the emergency room, but not always. Frequently, their patients are coming from assisted living, or they're living alone. So who's going to contradict people? The problem is not that these people come in with altered mental status and we don't have the capacity or the ability or the equipment to diagnose a TBI. The problem is that we assume that it is not a TBI in older people and we don't look for it. Okay, so let's look at these patients who present to the ED with altered mental status. Let's hit next one more time. All right, look at these gray-haired old people who come in with altered mental status. Do you think these people are going to get the same workup as people who are 30 or 40 years old? Well, let's take a look at their faces. And hit next again. Albert Einstein was teaching at Princeton, teaching astrophysics and relativity until he was 76 years old. If he rolled into an emergency room and he had altered mental status, do you think people who didn't know Einstein would assume that he was still teaching at 76? Probably not. What about Madeleine Albright? She was in the White House at age 67 and advising the president. Ronald Reagan was 75 in this picture and was the president. So if we were to look at these people and not know what they were doing, we would have different assumptions about them, and we wouldn't think that they had a TBI. We would just assume that they had dementia. Can any of you keep up with Dolly Parton's schedule at the age of 75? Probably not. Raquel Welch at 75? Never mind what she looks like, she's very busy and very active and very cognitively appropriate at her age. But the assumptions when we see people with gray hair are not the same assumptions that we make in younger people with regard to TBI and loss of cognitive function. Next slide. Okay, so in short, the problem that we have with TBI in older people is not a failure to recognize clinical evidence. In other words, the problem is not that we're not seeing it on MRI, we're not seeing it with our neurologic exams and things like that. What's the problem is that we're not considering that TBI could be in the differential because of our inherent age bias. A professor of mine used to say, what you don't see in the mind, you don't see in your eyes, right? If you're not looking for it, you don't see it, even if it's right in front of your face. Often TBIs are misdiagnosed as dementia, which brings up the question, can you distinguish a concussion from dementia? We'll discuss that on the next slide. So what are the repercussions of this? If you fail to properly diagnose a patient with a TBI, that patient is never going to get in front of Dr. Chen. That patient's never going to get in front of the appropriate therapists who are able to work with this patient. And therefore, they're never going to get the right treatment that can bring them back to their level of functioning as before. All because somebody made assumptions. We've deprived them of treatment that we know works. We've effectively ended their lives because we failed to think about it. So we have to be self-aware about our assumptions about age. And we have to maintain a high index of suspicion for traumatic brain injury. So now let's look at the differences between TBI and dementia. I'll save you some of the reading. TBI and dementia both are represented by diffuse and broad loss of function. And TBI and dementia both manifest with maladaptive behaviors, apathy, restlessness, loss of memory, loss of impulse control, emotional ability, irritability, language deficit, and aggression. If the symptoms are the same and we can't distinguish them, how do you think the doctors and the nurses at rehabs are going to distinguish them when they show up at their front door with an incorrect diagnosis of dementia? They're not going to know the difference, and neither are the therapists. So they're not going to undergo the appropriate treatment. Instead, the assumption will be that they have dementia and these behaviors, these maladaptive behaviors, restlessness, loss of impulse control, the emotional ability, do you think those are going to be treated with appropriate therapy? No. They're going to be treated with antipsychotics. They're going to receive Haldol because it's easy and because they don't have pharmacies. So the Haldol happens to be available. So they'll get Haldol, and then when the doctor comes and does their history and physical, maybe a week later, they may convert it over to one of the other newer antipsychotics that does less damage or impairs the healing less, right? So you can imagine what the repercussions are. So in order to recognize the TBI, again, you have to adjust your index of suspicion. You need to make sure that if you don't work in the ER, you at least talk to the ER physicians and the NPs and the nurse practitioners when you were consulted on a patient. You need to ask them, when did they come in? Did you talk to family members? Did you do a workup to rule out TBI? You have to be aware of your own age bias. Did you consider the fact that it could be a TBI? You have to do thorough information gathering. It's not enough to say, how old are they? Did they used to smoke? Are they married? You also need to ask, what were they doing yesterday? Are they horseback riders? Do they walk? Do they play tennis? Do they have stairs in their house? Do they live alone, right? And then you have to determine the pre-injury physical and cognitive baseline. And that can be sometimes tricky to do, but just because somebody has a concussion doesn't mean that they can't answer the question, do you like to bicycle? Do you like to play tennis? Do you like to walk? They may or may not be able to, but they're probably not going to confabulate it. You can also look at them. What are they wearing? What kind of shoes are they wearing? You can look through their identification and see if there's a membership to a club, a sports club or something like that. And you can contact their family members and be proactive about that, even if they are not in the emergency department, or even if they're not in the nursing and rehab facility. Reach out to them and find out from them what was their level of functioning. One of my biggest pet peeves is when I read a history and physical and I see people say they were at their normal level of functioning yesterday. What does that mean? unless they elaborate. Okay. So the final bullet that I did put on here is you need to be very, very skeptical, and you need to read other people's examinations very carefully and see if they add up. All right, so now let's talk about fall prevention. I think most of us know how we prevent a fall and what we do in order to prevent injuries when people fall. Safety devices are very simple and very available. Helmets, seatbelts, child gates to prevent people from falling down the stairs. Of course, moving people into flat plan housing where there's fewer stairs. Those are all readily available and easily accessible safety devices. Home assessments, you can check people's lighting, you can look for clutter in their houses, carpets with edges, stairs, door jambs, things like that. Those can all be assessed either by you or by an occupational therapist or even by interviewing family members. Medical assessments, well, you could assess the patient and find out if they are somebody who has difficulty with walking. You can find out why were they up in the middle of the night walking to the bathroom so that they fell over. Well, maybe they were getting up and walking to the bathroom because they have to pee in the middle of the night. And they have to pee in the middle of the night because they have bladder spasms. Maybe that's something you should treat. Or maybe they have to pee in the middle of the night because somebody prescribed their diuretic at 8 o'clock at night. And so, of course, we're making them pee in the middle of the night. So you need to manage medications, and you need to find out what it is that's causing them to have issues that cause them to have to suddenly get up from their chair and walk quickly. And if they get up from their chair and walk quickly, do they get orthostatic hypotension because we have them on too many antihypertensive medications? Because they were put on them 25 years ago and nobody ever changed them? That happens all the time. What about the fact that people, as I said, are blind or they can't hear or they don't have appropriate lighting in their houses? You need to address those issues. Also, you need to do a physical assessment. Not only a medical assessment, but you also need to do a physical assessment, the kind that is done by therapists, so they can evaluate their gait and their ability to lift their feet and their ability to navigate their homes. You also need to interview family members and find out how well they're doing in their homes. Now, here's a question that most of us don't ask. Should we protect all of our elderly from falls? Right? A big question is, and we often think about this. People fall, therefore, and they get injured and they cause TBIs, therefore we should stop them from falling. But is that always true? In an older person, are we always protecting them, or are we in some cases infantilizing them and revoking their rights? Let's look at this one person. Let's look at this 71-year-old guy. Look at him. He looks like he's going to fall at any minute. And what's he doing wearing those clothes that are inappropriate for a guy of his age? Let's look at the next picture. If we tell him he can't get up from his chair without assistance and he has to wear a helmet, how do you think this tightrope walker is going to take that? Are we protecting him? Does he want our protection? What's the next slide? I don't think Philip Petit, who walked between the Twin Towers in the 1970s, is necessarily in need of our protection. And he also doesn't want our protection. Next slide. This person, if you look at just the statistics, we would assume, oh, he's amongst the 71% of people who have dementia. Otherwise, why would he be talking about tightrope walking? He's obviously demented and he is unable to care for himself. But Philip Petit, at the age of 71, is giving lectures on a regular basis to younger people and teaching them how to surpass goals and reach goals and how to build up your skills so that you can do simple things or complicated things like walk on tightropes. He's in better shape than most of the people in this room. He's certainly in better shape than me. Are we helping him by preventing him from falling? Or should we, in fact, hire him to help us to understand what it's like to be 71? And then help us and help some of our patients to understand how we can make them stronger and increase their confidence.
Yes,
So let's
we
go
have
back.
10 minutes remaining.
All right, thank you. So let's go back to our case here. The 81-year-old I told you about who went to the ER and effectively he had altered mental status. Well, let's skip to the next slide. Are these the people you were picturing? Probably not. But classically, these are the kind of people who get shunted to the PA or the NP, who are fine clinicians. I'm not telling you that they're not. But those people, their job is to get people into the ER and out of the ER as quickly as possible. And the diagnosis of availability for altered mental status for older people is delirium from sepsis. And when they go and they get those lab tests and they say, go get a urinalysis, how do you think the tech in the ER gets that urinalysis? Do you think they necessarily get the person up and have them go walk to the bathroom and they do a clean catch? Nope. Often what they'll do is they'll just dip the urine stick right in that little pee can right next to their bed. And do you think that's contaminated with bacteria? Of course it is. And so there you have your diagnosis of urinalysis of a positive urinary tract infection. Give the person antibiotics and send them home. And we haven't even considered the fact that the gentleman who came in slipped and fell and struck his head on the wire of the net and got a TBI, or fell over while running a marathon and hit their head, right? So, and did we interview the EMTs that picked the person up? Or is the EMT off flirting with the nurse right now? So consider these factors.
So some conclusions from the wide range of topics we've covered today about the geriatric TBI population. First of all, further research needs to be done. It's the fastest growing population in the US, and the numbers of TBI in this population continue to increase, and there's very little research. There's very little guideline regarding treatment, but there are specific considerations that need to be made in treating these patients. Due to the pathophysiology of the changes in the brain and the comorbidities that occur in this age and this population. And in general, there needs to be a higher index of suspicion for TBI with falls in the elderly to minimize misdiagnosis, to get the right treatments, including rehabilitation, where they can make good cognitive recovery over time. And in general, further education needs to be done regarding fall prevention in the elderly, but also maintaining their independence and not infantilizing these patients and providing the ability to recover their the best function that they can have prior to the traumatic brain injury. So that concludes our presentation. If we could, any questions? I don't have the Q&A up.
Yes. I'd like to thank Dr. Chen and Dr. Fish for this presentation, and Dr. Fish for your continuing service to this country. Now, any of our attendees who may have questions, please pop them into the Q&A box. And when you have signed in, please identify yourself with your full name. So we're looking for your questions at this time.
And we have just over 5 minutes remaining for questions.
Are there any comments maybe regarding TBI in the elderly and any kind of experiences that you've seen in your own work or in your own lives?
I have to duck out. I'd like to thank everybody. Dr. Chen will manage the questions, and if there's any questions specific for me, then people can be put in touch with me after the fact. I appreciate your attention. I'm going to leave it to Dr. Chen. Thank you.
Thank you.
Dr. Fish. So it looks like Emily, thank you. She wanted to make a comment about TBI in the geriatric population, as too many people's families have a hard time seeing changes earlier on before the fall. That's a good point. that's true. We didn't discuss that at all, that it's kind of a gradual decline, and it's harder to, often families don't notice the gradual decline. So there is thought that maybe that we should be doing some baseline testing, almost similar to, impact testing and concussions. Dr. Fish did mention that there is a MACE test that they're using in military services, where they're looking at baseline cognition before military service and then after. And maybe there is a role that's needed for that as well. As well as neuromuscular and orthopedic. Emily mentions not just cognitive, but also neuromuscular and orthopedic changes as well. That's true. Any additional input about TME related to this topic? Mackenzie Breitowich, I'm not really sure what you're referring to with TME. And Alfonso Thomas says the elderly population is a unique group, and special consideration to them definitely should be considered. Mackenzie. Okay, so any additional input about toxic metabolic encephalopathy related to this topic? So I think that's a good point. And when Dr. Fish mentioned the case, he talked about delirium due to sepsis, which is commonly also called toxic metabolic encephalopathy, or and then the non-traumatic brain injury of encephalopathy due to possible other causes of encephalopathy. I think it's hard to tease that out. And often when you have a TBI that's a concussion and doesn't have any findings on imaging, that is often the diagnosis that's placed as toxic metabolic encephalopathy. It's really difficult to weed those out, I think, and often they are both co-diagnoses that you'll see in the elderly population. And the answer is catch them both, do the treatment for both. Make sure you understand that you're looking at a TBI, but also looking at encephalopathy. Both of them should hopefully clear over time to get back to a cognitive recovery. Just takes a longer time. So that is an excellent point, Mackenzie. Danielle Pagani, in your opinion, how can we as caregivers find a balance between helping our loved ones to maintain their independence and guiding them to care? That's a great question. And I think that was a big ethical question that Dr. Fish wanted to bring up. It's hard to try to maintain their independence, but also try to teach them about fall prevention. I think it's a really, we under-assess these patients, as Emily had mentioned earlier in her comments about getting a baseline test. We under-assess their baseline functioning and their baseline, physical functioning and cognitive functioning. If we had a better assessment of that, we could maintain that level and then also add additional things to prevent falls and prevent further TBIs. So there should be a balance, but I think we don't assess it enough to really find that balance. But I think as a caregiver, to really check in frequently on how the patient's doing, to really be on top of your loved one is really important to also maintain their independence, but also understand where they are having deficits. But that was a great comment. Thank you, Danielle.
Dr. Chen, do you have any last thoughts?
There's one more question from Laura Jacobs. How is the best way to help loved ones that have a bias about using a cane to prevent falls? I think that's difficult. And I think that goes back to finding an assessment for them. Maybe trying to get their buy-in to at least get one assessment to see how they're really doing in the safest way to do it, while maintaining their ability to have their independence and have their ability to use whatever they could feel most comfortable with. That's the safest. It's a fine balance. So I want to thank you all for your participation and for your attention. And I hope this was a helpful presentation. There's definitely so much more to come in research in the geriatric population. And hopefully we will see more of that in the future. Thank you again. And I hope you enjoy the rest of the conference today.
Thank you so much, Dr. Chen, and thank Dr. Fish for us as well. Everybody, the next session will begin at 1:50, and we hope that you join us for one of those workshops. Also, I'm putting the evaluation into the chat box right now, and please make sure to fill that out and to reach out to the presenters with any additional questions. Have a wonderful day and enjoy the rest of the seminar. Thank you so much.
Thank you.
All right, it looks like we do still have some attendees in the room. I'm going to leave the room open for the time being so that people can click on the evaluation, but you're free to go and enjoy the rest of the seminar.